Hey, hi, good afternoon, and thank you for the invitation. I'm very, very sorry that I can't be there in person because I'm sure the weather in Athens is much better than it is in Glasgow, but we're coming to Athens next week for one of our own meetings, so unfortunately I have to be online today. So I understand, can you see the slides?
Yes, definitely, yeah.
Okay, great. I'll just go full screen presentation. So I know that many of you in the room will be familiar with the ALLEGRA device now, and of course, I gather there was a live-in-a-box case of a valve-in-valve with ALLEGRA earlier, and I will spend the next 10 or 15 minutes just going through some of the features that you can use to identify which patients benefit from ALLEGRA most, because of course it's a very competitive field now, TAVI. There are multiple devices to choose from, and they're not all suitable for every patient. My conflict of interest is that at least for the next couple of days, I'm the Chief Medical Officer of Biosensors. I've been in this post for 4 years, but I'm handing over to my cardiac surgical colleague, Anders Johnson, next month, and we'll be making more time to do more proctoring of ALLEGRA cases. So as you can see, it's quite different from the main self-expanding TAVI device, the Evolute, that has been on the market now for many, many years. It is self-expanding and it is supraannular. It has bovine pericardium rather than porcine. It has a completely different stent frame shape to the Evolute. It actually opens out at the level of the new valve rather than have a waist as the Evolute does. It has tailored radial force. So the inflow part of the frame has high radial force for good fixation and anchoring, but the outflow has much lower radial force to allow the frame to move. And this is what the bioengineers call pole movement, and I'll come back to that in a moment. It has 6 gold markers positioned in pairs either side of the commissurial fixation points, which show you where the new valve plane is and also facilitate commissurial alignment. And again, I'll come back to that. Because of the design, it has very, very good hemodynamics. And generally speaking, we see effective orifice areas in the range of high 1.9 to 2.0 or even higher. Coronary access is very good. The whole package is designed for durability, and I won't spend much time on it, but it has a pretty unique permaflow occlusion-free delivery system, which I guess you saw in action earlier. So which patients can benefit from ALLEGRA? Well, I think the first cohort of patients you need to think about are those who have a high risk of prosthesis-patient mismatch. And particularly we're thinking here of small native annuli and, of course, the valve-in-valve. And we're starting to see TAVI and TAVI. So just to demonstrate this with a case, so I'll just go back. This is courtesy of my friend and colleague, Dr. Mohammed Al-Khalil at the Freeman Hospital in Newcastle, 78-year-old lady with severe aortic stenosis and a range of comorbidities. The vascular system suitable for a transfemoral approach, albeit that there's a little bit of disease. But you can see the first problem, a very small annulus area of 278 square millimeters, perimeter of only 61.8. And with, you know, calcification in all 3 leaflets extending to the base of the valve. So this patient's 148 centimeters, 76 kilos, body surface area 1.8 meters squared. I've just been listening to some fantastic presentations by your extremely experienced and talented cardiac surgeons. And if this lady was going for surgery, in order, with a body surface area of 1.8, in order to avoid prosthesis patient mismatch, as you can see here, they would have to put in a 25 millimeter valve. That's pretty unlikely to happen. A 23 is, of course, better, but still you've got an indexed effective orifice area of 0.83, which is at least moderate PPM. And if she ends up with a 21, then she's basically got severe PPM to start with an index EOA of 0.72. The transcatheter options would include a Sapien 20 and an Evolute 23. You wouldn't be able to get anything bigger than this into this annulus, at least not safely. Now, if you calculate the predicted prosthesis patient mismatch figures or the index effective orifice area for the the sapien here in yellow and the evolute in green, you can see figures of 0.78 for the sapien, so that's at least moderate ppm. The evolute just gets to 0.92, so it's just about getting there. And that is definitely an option. But in this case, the operator chose to implant a 23mm ALLEGRA. So you've seen this before, ultrasound-guided femoral access, pre-dilatation, which is something that we mandate in the IFU, although we're starting to see more cases being done without pre-dilatation. We position using the gold markers and the ring marker here on the delivery system to optimize the implant depth, aiming for somewhere in the region of 3 to 4 millimeters below the non-coronary cusp. And you can see here the release of the inflow. It looks a little bit deep initially, but in fact, when you correct for the parallax by bringing the gold markers into line in the middle panel, you'll see that this is a very nice implant depth. The delivery system is retrieved. And then we have a final result on the left here, actually in this case with no need for post-dilatation, there's no PVL. This patient was actually discharged on the same day of the procedure. And at 4 weeks, the echo showed a mean pressure gradient of 8 millimeters of mercury and an EOA of 2.03 centimeters squared, giving an indexed EOA of 1.13. So absolutely no prosthesis patient mismatch here, despite a very small native annulus. And I think this is a great demonstration of the hemodynamic benefits of ALLEGRA in this situation. Now, of course, you saw a valve-in-valve this morning. This is the trifecta 21 with a true ID of 19. And in this setting, the ALLEGRA is really probably the first choice and is beginning to become so in many cath labs for valve-in-valve. And I draw your attention also to the fact that we have perfect commissural alignment here with the right coronary being right underneath one of the T-bars of the valves. That means that it's at the nadir of the semilunar junction of the new valve. And I'll clarify how that's done in a moment. We're starting to see, as I say, some TAVI and TAVI referrals for ALLEGRA, mainly sapien, of course, because sapien's been around for a long time. You can see how well the ALLEGRA fits inside this degenerated sapien XT. But we are also starting to see referrals for ALLEGRA in degenerated evolute. Now you might ask, why don't you want to put a sapien in here? Well, I think the first problem is that the hemodynamics won't be so good. The second problem is leaflet overhang, and you don't get leaflet overhang with the ALLEGRA. We always post-dilate in the valve-in-valve setting to make sure that both frames are as opposed to each other as possible. This was actually done in Dusseldorf a couple of months ago with myself as the proctor and Tobias Joyce as the operator. Now, the next group of patients who potentially benefit from ALLEGRA are those who need a really durable result. And there's a couple of things that play into the long-term durability of the ALLEGRA device. The first one is the pole movement, which I mentioned. So this valve is designed such that the outflow flexes with each cardiac cycle. You can see it here in the pulse duplicator in a short axis and a long axis view. And this movement of the frame with each cardiac cycle dissipates leaflet stress. And of course, leaflet stress has a direct relationship with valve durability. In a slightly more dramatic way, you can see here in these videos a series of different TAVI devices. So this is the sapien on the left, the Evolute R, and the second from the left, the Accurate Neo here on the right, and then the ALLEGRA on the far right. And watch the fluttering of the leaflets. So the sapien, of course, is a short height frame, relatively rigid. There isn't too much fluttering of the sapien leaflets, but the Evolute R and the Accurate Neo in particular have tremendous fluttering during each cardiac cycle. Contrast that with the opening of the ALLEGRA, which is absolutely stable. And this is another reason why we think that the ALLEGRA will likely have high durability. And if you formally assess this, and by the way, this is a publication from a cardiothoracic surgical journal, completely independent of of biosensors in terms of either study design or funding, you can imagine that the ALLEGRA will indeed have considerable durability. Now, of course, it's not been around that long, so we don't have very long-term data with ALLEGRA. This is the first in human study done back in 2014-15. Only 74 patients. You can see the hemodynamic results at 30 days. 27 of these patients survived to have a 5-year echocardiographic follow-up. Of course, they were all very high-risk patients to start with. Sorry. And you can see that the hemodynamic performance of the valve is preserved all the way out for 5 years. There's no sign of any structural valve deterioration, albeit these are survivors, of course. And again, I want to show you a single case. This time it's courtesy of Professor Alexander Abizade from Sao Paulo in Brazil, who is one of the first cardiologists to use the ALLEGRA device. 84-year-old lady with, again, with severe aortic stenosis, peak gradient 79, mean 50. And because this is one of the first cases that was ever done, you can see they've got TOE guidance, 3-cusp view, pre-dilatation, the valve being delivered on the right-hand panel. And of course, you know, quite a lot of care being taken because this valve at this point had barely been used in any humans. So you can see we go into the permaflow position with the delivery system. Again, the same markers as we have now. A ring marker at 4 millimeters, the gold markers at 12 millimeters. We open the inflow. This time there is some PVL, as you can see in the right-hand panel. So they do a post-dilatation. Final result, probably still residual mild PBL, but remembering this was 2015, probably acceptable not to go any more aggressively with the post-dilatation. Certainly the forward flow hemodynamics were good with a trivial peak gradient. And the interesting thing about this patient is that she's come back for 8-year follow-up and is effectively asymptomatic. Here's the echo at 8 years with a mean gradient of 2.25 millimeters of mercury, which is remarkably low. Preserved ejection fraction, very low gradient, and effective orifice area that is still almost 1.9 square centimeters, despite the fact that this was a small lady with a small valve. And you can see that the PVL is pretty well gone, as you might have expected. It's probably gone within the first few weeks, in fact. And the last group of patients I want to talk about who would benefit from ALLEGRA are those in whom commissural alignment is important. And by commissural alignment, of course, we mean in most patients also coronary alignment. And clearly the cardiac surgeons do this routinely because they can see the coronary arteries when they are implanting their valves, and they rotate them to make sure that they don't leave a commissural post in front of one of the coronaries. In the ALLEGRA, commissural alignment is facilitated by the gold markers. So we have 3 commissures, of course, and there are 3 pairs of gold markers on each side of one of the commissures. There are 3 T-bars to fix the valve to the delivery system, and each commissure, each T-bar is opposite one of the commissures, as you can see here. So T-bar, T-bar, T-bar. Now, when we go in, we load the valve so that one of the T-bars is in line with this flush port. So if the right coronary artery is anterior, as it is in almost 90% of patients, we would go in at 12 o'clock. If the right coronary artery was a little bit LAO or RAO, we would go at 1 o'clock or 11 o'clock. And then this is the pattern of gold markers that you'll see when you go into the permaflow position if you're fully aligned. So you will see a single marker on the outside of the valve frame, overlapping an overlapping pair either side of the guide wire, which goes straight through the middle between the markers. And I'll just zoom that up. So single markers on the outside, overlapping markers on the inside, and the guide wire through the middle. And this confirms that you've got complete commissural alignment before you open the valve, of course. And if you want to check it in a cusp overlap view, then this is the pattern you'll see. In cusp overlap, it's different, of course. You'll see 3 overlapping pairs with a short distance between on the screen, the left and the central pair, and a longer distance between the central and the right-sided pair. And actually, as you can see, this is a valve-in-valve case in a Percival, which tells you that you don't always get a durable result with a sutureless surgical valves. So again, just to exemplify this with a case report, this is courtesy of Stefan Togweiler in Lucerne. So an 84-year-old lady who also has severe disease in the mid-LED, so coronary access is important. Now, ordinarily, I mean, even Stefan would admit that he does the PCI before the TAVI, but in this case, just to prove the point, he did the PCI immediately after the TAVI. So you can see he has a technique where he puts the pigtail on the right coronary cusp rather than the non. This allows him to be sure that he's got a good three-cusp view, and then he leaves it in the right coronary cusp to confirm that he's got a good cusp overlap view. He implants in cusp overlap to minimize foreshortening and make sure that he's implanting as high as possible. That's primarily related to minimizing the risk of conduction system disturbance. You'll see the opening of the valve here. It looks very high, almost at zero. In fact, when the parallax is corrected, it's probably 1 to 2 millimeters on the non and pretty similar on the left. There is some PVL. He does a post-dilatation. You can see the frame expanding. This is a valve that responds well to post-dilatation. And now the PVL is virtually completely abolished. And this is the neat thing. So immediately after the TAVI has been implanted, he goes on to do the PCI to the mid-LED. This is a live, real-time recording. So this has not been edited. This is his technique for getting into the left coronary artery. He's using a JL35. He uses a wire to make sure he's in the middle of the frame of the ALLEGRA. Once he's in the middle of the frame, he brings in the JL35. We know where the coronaries are in relation to these gold markers, and then see on the right. So that was somewhere in the region of 10 to 12 seconds to cannulate the left coronary artery. He goes on to do the PCI in the usual way with a guide liner to protect the frame, delivers 2 stents in the LED and a nice final result. And then this is the echo the day after, no PVL, mean gradient 4, which is the sort of result that we commonly see with ALLEGRA and discharge of 48 hours this time rather than on the same day. So in conclusion, I just want to emphasize that the ALLEGRA is a great valve for many, many patients, but if you want to selectively use the ALLEGRA in patients who will benefit most from its features, we would recommend that those be the patients with a high risk of prosthesis-patient mismatch, so small native annuli and valve-in-valve. Patients requiring a highly durable result, which of course speaks to the younger patient population who are coming for TAVI now rather than surgical AVR. And lastly, patients who require commissural and therefore coronary alignment. In other words, those who have a high risk of coronary occlusion because of their native anatomy, and patients who have concomitant coronary disease who might need to come back to the lab at some point for revascularization. So thank you again for listening, and I'm happy to try and take any questions.
Okay, so thank you, Professor Oldroyd. So this was really interesting and a very, very informative presentation. So this is the target area, the patient population, and my co-moderator, Dr. Triantafyllou, has experience with ALLEGRA as well. Maybe he can share his experience with us. So it's a very good valve for small annuli and with patients, with young patients with coronary access considerations for the future. Are you worried at all in this category of patients to place, let's say, for a first valve, to place a supraannular valve instead of annular, to be followed like in a TAV procedure with a supraannular? So do you think it's a good practice to place a supraannular valve as a first valve in a young patient?
Is the question to me?
Yes.
Right, okay, sorry. Yeah, no, it's an interesting point. Well, I think I think a strategy of going balloon expandable first, followed by self-expanding in the event of degeneration is perfectly feasible. However, I would say that the ALLEGRA, we haven't actually had to do an ALLEGRA procedure so far. I mean, the device has been commercialized since 2017 and it's been implanted in studies since 2015. So this is coming up for 10 years. We're approaching 4,000 implants, and we haven't had to do an ALLEGRA. But if we did, so if the patient had started with an ALLEGRA and then the valve degenerates, it's entirely feasible to place a second ALLEGRA inside the first one. So, you know, that is a potential strategy, which means that you could spend the best part of, let's say, 15 or 20 years with a supraannular valve with excellent hemodynamics. Because we know for sure that if you go with a sapien in small native anatomy, the hemodynamic results will not be so good.
Good point. So, Kostas, Dr. Triantafyllou.
Congratulations for the presentation. You were very clear to show us the indication of this new platform. I would like you to stress any limitations regarding anatomies that we should avoid using this platform. For example, we had tried it in a few cases for small annuli. We even did the valve-in-valve with good results in our center. We have our initial experience. But I would like you to tell us, from your experience, which patients are not expected to be treated in the best way with this platform.
Yeah, of course. I mean, clearly, when I'm emphasizing the patients that it's best for, then clearly there are patients in whom it's less suitable for. So, for instance, you know, we do not particularly recommend ALLEGRA in large anatomies where we think that the balloon expandable devices are probably the best and the hemodynamic differences are less of an issue. We do not routinely recommend the ALLEGRA valve for bicuspid valves. That's partly because the CE mark does not incorporate the indication of bicuspid aortic valves. I have to say that we have centers in Spain and Italy who are using it in that setting, but they're experienced ALLEGRA users. The other issue in that setting with complex anatomy like bicuspid heavily calcified valves is that the current version of the ALLEGRA is not fully repositionable. It can be recaptured and then removed and then loaded on a new delivery system, and you can start again if the valve pops up or if it's too deep. The second generation delivery system, which we call Ampitheatre, is fully repositionable. The clinical studies for that delivery system have been completed. The data was submitted for a CE mark about 1 month ago. And of course, because of the delays at the moment with medical device regulations in Europe, we don't expect to get a CE mark for that device until the middle of next year. When we do, we would certainly want to start extending the use of ALLEGRA into the more complex, heavily calcified bicuspid anatomies.
So, excellent. Are there any comments, questions from the audience?
What about the pacemaker implantation rate? Yes.
Yeah. So, of course, I mean, you saw the high implantation technique that's practiced by Stefan Togweiler in Lucerne. He's done about 140 ALLEGRAs. His pacemaker rate is somewhere between 6 and 7%. I'd have to say that that is quite low. The average pacemaker rate that we see across, you know, the 3,500 cases that we've done so far is more in the range of 10 to 12%. As you might expect with a self-expanding valve. So if you go high, you can get a lower pacemaker rate, but safe implantation with an implant depth, let's say somewhere between 2 and 4 millimeters in the LVOT on the non-coronary cusp side, you're probably going to expect a pacemaker rate of somewhere in the 10 to 12% range.
Good. So, Professor Oldroyd, thank you so much. So, hopefully we'll see you next week in Athens.
Yep.
And thank you for all this very useful information. So, thank you.
Thank you very much.